Oral irrigators may be contraindicated in patients requiring antibiotic premedication prior to dental treatment since these devices have the potential for causing a bacteremia. The patient's physician should be consulted. Remember, the pathology associated with gingivitis is completely reversible with the removal of plaque and the resolution of the inflammation. Question. Question. Trauma from occlusion can produce radiographically detectable changes in all of the following except one. Which one is the exception? Lamina dura, periodontal pockets, width of the periodontal ligament space, morphology of the alveolar crest, density of the surrounding cancellous bone. The answer is all of them except periodontal pockets. Trauma from occlusion can reduce radiographically detectable changes in all the following except periodontal pockets. Periodontal pockets are not caused by occlusal trauma. A local irritant and inflammation are necessary to cause apical shift of the epithelial attachment. The most common clinical sign of occlusal trauma is tooth mobility. Again, the most common cause clinical sign of occlusal trauma is tooth mobility. Other clinical signs of occlusal trauma include migration of teeth and the tenderness of teeth to percussion. Traumatic lesions manifest more clearly in the faciolingual aspects because mesiodistally the tooth has the added stability provided by the contact areas with adjacent teeth. Radiographic signs of trauma from occlusion: widening of the periodontal ligament space, thickening of the lamina dura, angular bone loss, and infrabony pocket formation. Root disruption, hypercementosis. Trauma from occlusion is reversible. That is, the body can repair the damage if the excessive occlusal forces are eliminated. Other findings associated with excessive occlusal forces: alternating areas of resorption and repair of the alveolar bone, fibrosis of the alveolar bone marrow spaces, segmental resorption leading to dentinal resorption, segmental tears, possible ankylosis, occlusal pulpal necrosis, and calcification. Radiographic changes that may be seen on teeth that are no longer in function: reduced trabeculation of bone, narrowing of the periodontal ligament space. Extrinsic dental stains include green to brown stains caused by erythroblastosis fetalis, brown, black, green, or orange stains caused by chromogenic bacterium plaque, red to brown stains caused by congenital porphyria, or gray or brownish stains caused by tetracycline. Answer is brown, black, green, or orange stains caused by chromogenic bacteria and plaque. Stains can be identified by location, intrinsic and extrinsic. In intrinsic, the stains that occur within the tooth substance, and extrinsic stains that occur in the external surface of the tooth. Stains can be identified by sources of the discoloration: endogenous and exogenous. Endogenous are stains that originate from within the tooth. Endogenous stains are always intrinsic, and frequently are uh, discolorations within the tooth. I mean, discolorations of the dentin reflected all throughout the enamel, through the enamel. Examples of sources: drugs like tetracycline or systemic fluoride, changes in pulp tissue or pulpless teeth, imperfect tooth development like amelogenesis imperfecta. Now, the exogenous sources of discoloration are stains that originate from the external source, from an external source. Brown, black, green, or orange stains are generally seen on the labial surface of the anterior teeth and are usually caused by poor oral hygiene. Some theories attribute the change in color to byproducts of some bacteria. Black stain is generally seen in the cervical portion of molar teeth in children. Green and orange stains are supposedly associated with an increased amount of caries, and actually they represent pigmentation of dental plaque. Black line, tobacco, orange, and green stains are all exogenous extrinsic stains, initially at least. With time, both green and tobacco stains may become incorporated within the tooth. At this point, the classification changes. They become exogenous intrinsic stains. Silver amalgam and topical fluoride are also examples of exogenous intrinsic stains. An exogenous intrinsic stain is one that originates from source outside the tooth and subsequently becomes incorporated within the tooth structure. The most common indication to splint mobile teeth is to improve patient comfort and provide better control of the occlusion in the anterior teeth if the anterior teeth are mobile. To improve oral hygiene, no. Prevent a natural unopposed tooth from migrating. Prevent maxillary center incisors from separating after closure of diastema. Answer is to improve patient comfort and to provide better control of the occlusion if the anterior teeth are mobile. Splinting therapy may be applied with bonded external appliances, intracoronal appliances, or indirect cast restorations to connect multiple teeth with the goal of improving stability. Unstable teeth may be caused by a lack of periodontal support from bone loss, a lack of support from tooth loss, or the need to splint abutment teeth to support pontics. Again, unstable teeth may be caused by a lack of periodontal support from bone loss, lack of support from tooth loss, or the need to splint abutment teeth to support pontics. There is no reason for splinting non-mobile teeth as a preventive measure. Splinting is only one measure used in the treatment of periodontal disease. Splinting should be used with other necessary measures such as root planning, oral hygiene instructions, pocket elimination, and occlusal adjustment. Loose teeth splinted to adjacent teeth may become stabilized. Stabilized, I meant. Loose teeth splintered to adjacent teeth may become stabilized. When many teeth are loose, adjacent sextants should be included in the splint. Teeth tend to loosen buccolingually, yet may remain firm mesiodistally. Even when teeth do not tighten, the splint serves as an orthopedic brace that permits useful function of loose teeth. Again, when many teeth are loose, adjacent sextants should be included in the splint. Teeth tend to loosen buccolingually, yet may remain firm mesiodistally. Even teeth, even with teeth, when teeth do not tighten, the splint serves as an orthopedic brace that permits useful function of loose teeth. A variety of means may be utilized to achieve temporary stabilization. Whatever means are used, special attention should be paid to making the splint amenable to oral hygiene procedures and instructing the patient on plaque control around the splint. Indications for splinting are mobility of teeth that is increasing or that impairs patient comfort. 2. Migration of teeth. 3. Prosthetics where multiple abutments are necessary. Before number 2 note, before considering splinting, the clinician must identify the etiology of the instability. Any inflammation on the periodontal supporting apparatus must be controlled before making a decision on splinting because inflammation can produce mobility in the presence of normal occlusal forces and normal periodontal support. Adequate crown length of the teeth being splinted is critical so that the interproximal connectors do not impinge on the interdental papilla. 4. Adequate space must exist between the connector and the papilla for access with dental floss anteriorly and with an interproximal brush on posterior teeth.